Excellent. Thank you, Eric. So let me share very quickly my screen. And just a quick check, can you see my screen?
Yes.
All right, thank you. All right, so we are ready to move to the next session. So this session focuses on AI in healthcare, algorithms and data bias and mitigation strategies. So this is the more technical session, and we have invited a number of people that are experts in AI and also are thinking deeply about the use of AI in healthcare. So I would like to introduce and welcome today Emma Pierson, who is an assistant professor in computer science at the Jacobs Technion-Cornell Institute at Cornell Tech. Rick Caruana, who is a senior principal researcher at Microsoft Research, and Jenna Wins, who is a professor at the University of Michigan of Computing and Engineering Sciences, and she's also the director of the Artificial Intelligence Lab at the University of Michigan. So I would like first to remind you that this session is being recorded and will be shared at the Hariri Institute YouTube page later this week. And with that, the plan for the session is we will start with presentations in the order I introduced the speakers, and then we'll have some time at the end for questions and the panel discussion by the three speakers. So with that, I'll stop sharing, and the floor is yours, Emma. Welcome.
Thanks very much for the introduction. I'm very excited to be here. I'll just share my screen. Share. Okay. Perfect. Can you see my slides?
Yes.
Wonderful. All right, great. So let's jump right into it. I'm Emma Pierson. I'm a professor at Cornell, as mentioned, and today I'll be talking about using machine learning to increase quality in healthcare. My two kittens, Mew and Sigma, have decided to join me, so they'll be collaborating on this presentation as well. So to motivate this talk, I'll point out three simple facts. The first is that healthcare and public health remain profoundly unequal. And COVID, of course, is the quintessential example of this. We see disparities in almost every COVID-related metric, but there are many others as well. Also well known, I think, is the fact that algorithms can exacerbate this inequality. And we see this, in healthcare algorithms, but in many other algorithmic domains as well. But today I want to focus on a more optimistic counterpoint, which is about how algorithms, data science, and machine learning properly applied can also reduce inequality in healthcare and public health. And I'm going to make that point to you by telling you three stories. Lightning quick, we're not going to get deep into the technical details, but I hope these vignettes will sort of give you a high-level understanding of why this more hopeful vision is realistic. So I'll be talking about disparities in pain, women's cycles, and disparities in COVID. So let's start by talking about disparities in pain. This is joint work with David Cutler, Yuri Leskovic, Sonal Melanathan, and Ziad Obermeyer. You can find it in Nature Medicine a couple of months ago. So a general fact about pain is that socioeconomically disadvantaged groups experience more of it. This is quite a robust finding. It's true across multiple continents, multiple sample types, etc. And it's true for racially disadvantaged groups as well. And this is also true in the condition I'll be talking about today, knee osteoarthritis. This is one of the most common causes of disabling pain in older adults. And in this condition, as in other conditions, disadvantaged groups experience greater pain. And this is true even when we control for how severe the doctor thinks their pain is. Now, how do we actually measure severity in osteoarthritis? Because obviously, that's going to crucially determine how severe we think someone's pain is, or how severe we think their disease is. Basically, what happens is that a radiologist looks at an X-ray of the patient's knee and assesses it on various clinical features of osteoarthritis and gives it a summary measure, summarizing the severity based on the features they can observe in the knee X-ray. But the severity score was developed decades ago in heavily white British populations. And so it's plausible that it doesn't capture all the features that are relevant to pain in modern and more diverse populations who may live and work very differently. So we're going to seek to use machine learning to assess whether there are overlooked physical features in the knee which might explain the higher pain levels in disadvantaged groups. Specifically, what we're going to do is we're going to train a deep learning algorithm, a convolutional neural network, to search for this additional signal in the knee X-ray to try and explain these higher pain levels. So what does that actually mean? How do we search for signal? Well, the standard approach to searching for signal in a medical image is to train a model to replicate the doctor's clinical judgment. In other words, train the model to predict the doctor-given severity score. Multiple papers have been written on exactly this task. But the problem here, of course, is that our whole hypothesis is that the doctor judgment might not capture all the features that are relevant to pain. And so we don't want to just seek to replicate clinical knowledge when the whole hypothesis is that that knowledge might be biased or incomplete. Instead, we're going to train the model to predict the patient's pain, to learn from the patient directly by predicting their pain score. So the input to the model is an X-ray of the patient's knees, and the output is a knee-specific pain prediction. And if controlling for the algorithmic severity score narrows racial pain disparities and socioeconomic pain disparities more than controlling for the clinician's severity score, it implies that the clinician's severity score overlooks knee features, which would help explain disadvantaged patients' higher pain levels. This is, in fact, exactly what we find. Controlling for the algorithm's severity score narrows unexplained disparities in pain by 2 to 5 times more than controlling for the traditional severity measure. The algorithm is also better able to predict pain overall than is the clinician. There are many robustness checks we do on this result, but I won't go into them now. 2 other results I briefly want to mention. The first is that we do an experiment on how the diversity of the train set alters algorithmic performance, and we find that using a diverse train set leads to improved algorithmic performance. This is important for the design of medical studies, which often suffer from a lack of socioeconomic, racial, gender, and other types of diversity. A second result is that because the algorithm tends to give disadvantaged patients higher severity scores, it is also more likely to allocate them surgery. This suggests the potential for reducing disparities in access to surgery by using algorithmic decision aids to supplement clinical decision making. Second story, women's cycles. This is joint work with Tim Althoff, Daniel Thomas, Paula Hillard, and Yuri Luskovic, and it was published in Nature Human Behavior, again, a couple months ago. So cycles are fundamental to human health. Daily cycles like circadian rhythms, weekly cycles like going out on Fridays, seasonal cycles like getting depressed in the winter, and of course the menstrual cycle, which itself has been implicated in numerous aspects of health. Now, how do people traditionally measure cycles? Well, one thing we've often done is you take some signal, and if you want to sort of see how that signal cycles over the population, you just take an average across the entire population at a single time point. So this is an example studying happiness cycles using Twitter data. The y-axis is plotting some measure of happiness as inferred from Twitter data. And basically to get the value at 3 p.m. on a Wednesday, they just take an average of the entire population at 3 p.m. on a Wednesday. But there's a problem with this, right? Which is that taking a population average will render the menstrual cycle and other individual specific cycles invisible, right? If you take an average across the entire population on January 3rd, then people are not going to be at the same point in their menstrual cycles on January 3rd. Their phases are going to be out of sync. And so you're going to wash out this source of variation. So if you want to study the menstrual cycle or other individual specific cycles that aren't synced across the entire population, then you need data on menstrual cycle starts. This is hard to get due to sort of general stigma around the menstrual cycle, which has led to a lack of medical data. There is good news, though, which is that the rise of women's health apps, which are now used by millions of people across more than 100 countries, allows for a very rich picture of people's lives. So today I'm going to be talking about data from the Clue Women's Health app, which tracks more than 100 features daily, everything from mood to pain to pregnancy, and crucially for our purposes, menstrual cycle starts. So we're going to use this to provide the first decomposition of mood, behavior, and vital signs into 4 simultaneous cycles, daily, weekly, seasonal, and menstrual, and thereby we're going to improve understanding of this fundamental aspect of women's health. Specifically, we're going to use multivariate linear regression to decompose the overall signal into 4 cycles. We're going to take each observation, so for example, mood for one person at one time point, and we're going to regress it on categorical variables, which capture the 4 cycles, one variable for hour of day, one for day of week, one for month of year, and one for day of menstrual cycle. And then the regression coefficients will capture those cycles. To be concrete about what that looks like, this graph shows the result for happy versus sad mood. Each graph plots one cycle, and basically what we're plotting on the y-axis are the regression coefficients. So you can see, for example, a dip in happiness prior to the menstrual cycle start, late at night, an increase in happiness on the weekends, a decrease in happiness near the start of the school year. This is sort of a predominantly young school-age population. You can also see that the menstrual cycle happiness amplitude is in fact the largest of these four cycles for this particular dimension of mood, behavior, and vital signs. The overall implication being this is why menstrual data is important. Without it, the largest cycle for this dimension is entirely invisible. And in fact, we looked at 15 dimensions, not just happiness, of mood, behavior, and vital signs, and found that the menstrual cycle has the largest amplitude of the four cycles for 11 of the 15 dimensions that we studied. Due to sort of the geographic diversity of our data set and the large size of our data set, we were also able to see sort of consistent patterns emerge across cultures. So for example, people consistently get sadder prior to their period start across all the countries we studied. So the overall takeaway here is not that women are more volatile, and there are a whole bunch of reasons that is not the implication of our results. We make no comparison across sexes and genders. Previous research has not found sex differences or gender differences in volatility. And an obvious reason for this is that males have hormone cycles too, they're just less focused on. And also that there are many other sources of variability besides cycles. So that's not the implication of the results. Rather, the implication is that the menstrual cycle is a primary cycle, and it has to be studied and destigmatized and normalized just the way the sleep cycle is. So that means, we need better data collection in health apps and in medical records. We need better consideration in the clinic, and we need broader cultural acceptance of the cycle. Like we need to sort of all grow up and talk about this in a normal way. Final story, disparities in COVID. This is joint work with Serena Chang, Pongwei Ko, Jillian Gerardine, Beth Redbird, David Grusky, and Yuri Leskovic, appeared in Nature a couple months back. So as you all know, viruses like COVID spread through human contact, which is to say that there's an underlying contact network that modulates the spread of the virus. A standard model is that an infected person can infect anyone she comes into contact with some probability. Those people then go on to infect their contacts, and you get the explosive spread of the virus across the network. As a consequence, understanding the structure of this human-human contact network is fundamental to modeling the spread of the virus. But of course, it's very difficult to know who everyone comes into contact with, right? Like this is a difficult thing to observe. And so current models have often used simplistic estimates of the underlying contact networks. For example, you might assume anyone can infect anyone, so the network is fully connected. Or you might use an airline network that captures trends, but only at a very high level, connecting city to city. Or you might rely on historical data from, say, 2015, and hope that the mobility and contact trends are the same as they were in 2015. But this isn't enough to understand the observed large disparities in infections that we've seen across racial and socioeconomic groups. So our approach is twofold. First, we're going to try and estimate these networks using cell phone mobility data and machine learning. And then on top of that, we're going to put a standard epidemiological model, an SEIR model, to model transmission over the networks. I'm not going to tell you in detail about how we do these things, these 80-page supplement to the paper or whatever it is, but I do want to tell you at a high level what these mathematical objects look like. The networks that we infer, and this shows one picture, captures the hourly traffic between neighborhoods and places in the United States. So neighborhoods are relatively small census areas with a couple hundred people, and places are like churches, restaurants, grocery stores, gyms, etc., places that people go when they're not at home. And so we then know the number of people flowing from each neighborhood to each place at each hour. It's quite a granular picture of human mobility. In total, our networks encompass about 500,000 places, tens of thousands of neighborhoods, and billions of hourly edges. Now, we put an epidemiological model on top of this, sort of the model spread across this network. I'm not going to describe the model in detail, but because it has such a fine-grained picture of mobility, we can use it to answer a number of sort of very relevant policy questions, like how much of an impact did social distancing have? What would happen if we reopened in various ways? And why do we see such large disparities in cases? I'm only going to talk about that last part because this is a talk about inequality. And in brief, the model is able to predict socioeconomic and racial disparities in infections across the 10 cities that we analyze on the basis of mobility patterns alone. So we don't tell it anything about who these people are. We don't tell it anything about the fact that some groups have higher infection rates. We merely give it the mobility data, and it naturally predicts that poor neighborhoods, for example, will have higher infection rates. It's also able to uncover two mechanisms that contribute to these disparities. The first is that people from lower income and less white neighborhoods were less able to reduce their mobility after COVID hit. And this is very plausibly linked to the fact that they were more likely to be essential workers. It was harder to work from home, and they had to go out more and face higher risk. A second mechanism is that when people from lower income and less white neighborhoods did go out, they went to places that were smaller and more crowded and therefore more dangerous. And this was true even within the same type of place. So to be very concrete, if someone from a rich neighborhood and a poor neighborhood both went to the grocery store, the person from the poor neighborhood would tend to have to go to a grocery store that was smaller and denser. And therefore, even in the course of living their daily lives in the exact same way, they were sort of inherently exposed to higher risk. I probably won't show you this video in great detail, but it basically, if you look at that map in the middle, the thing that says log 10 faction ever infected, it shows you for Philadelphia where the model thinks that people are getting infected. You can see the growth of the red stain at the city center. That's where the model thinks infection rates are highest. And you can see that that naturally sort of lines up with the areas of highest population density and lowest household income. So that's the connection between kind of population density and between infection rates and between income. And an obvious corollary of this is that it's very important that reopening plans consider not just the impact on the population as a whole, but specifically the impact on disadvantaged groups. Okay, I'd like to close by summarizing and saying that today, in some sense, I've told you the same story 3 times. Now, of course, the data and the methods and so on looked extremely different, but in all cases, we had some sort of question of immediate relevance to an underserved population that we were trying to study. You know, are there causes of pain? Why are there COVID disparities? And sort of just looking at the population as a whole or relying on conventional statistical methods were inadequate to study them. And by using machine learning and AI approaches, we're given sort of a powerful lens to focus in on the problems of these groups. And that's why I think that AI can potentially be a powerful force for equality. We just need to prioritize focusing on groups that we've previously been blind to. Thanks very much. I'm looking forward to the subsequent discussion.
Thank you very much, Emma. So we will hold questions until the end. For those of you that are participating, feel free to put your questions into Q&A. Chat has been disabled for participants. So next, I would like to introduce Rick. As I mentioned, Rick Caruana. He's with Microsoft. And Rick, the floor is yours.
Thank you. Share my screen. Hey, Emma, that was a great presentation. Enjoyed that a lot. Okay, are you able to see my screen in presenter mode?
Yes, thank you.
Excellent, excellent. Okay, I'm going to talk about the risk of using black box models in healthcare and the value of intelligibility. Before I start, I just want to say many people have worked with me on this project, including some great graduate students, Yin, Shuzhou, Ben, Kingsley, some people at Microsoft, and doctors and other collaborators at hospitals and universities. Here's how I got interested in this. Back when I was a grad student at CMU, my advisor asked me to train a neural net on a pneumonia risk problem. The goal is to differentiate between high risk and low risk pneumonia patients. The low risk patients can be treated as outpatients, but the high risk patients definitely need to be admitted to the hospital. And about 10–11% of the patients in our data set die. So if you're high risk, you definitely need to be in the hospital or ICU. Now, the neural net I trained turned out to be the most accurate model any of the many teams working on this data set could train. So that was great. And the question arose, should we try using this on real patients, use it clinically? I thought about it just for a minute or two and said, no, we should not trust this neural net. It was a big neural net. It had 10 million weights in it back then. And I said, no, we shouldn't use this. And one of the reasons was a friend who was doing rule-based learning with the same data set had a year earlier learned this funny rule that if you have a history of asthma, it lowers your chance of dying from pneumonia. That is, asthma, it looks like it's good for you, protective if you've got pneumonia. So we asked the doctors about that because, you know, it doesn't sound right. And the doctor said, wow, asthmatics are definitely at higher risk from pneumonia. You have to fix the model, so that's a problem right away. And then they said, but it might be a real statistic in the data. Asthmatics notice the symptoms of pneumonia probably earlier. They try their inhaler, their meds don't work because that's not what they're designed for. They have a doctor who treats their asthma. The doctor says, oh, that didn't work, get in here. They get an appointment quickly. And then the doctor hopefully diagnoses that they've got pneumonia. They're actually considered to be a higher risk patient. So they get very aggressive treatment. And this combination of getting to care quickly and then getting very high quality care once you get there, turns out it does lower the chance of dying of an asthmatic compared to the general population who doesn't get to care and aggressive treatment as quickly. So the asthmatics are in some sense lower risk, but they're only lower risk because they actually get higher, faster quality care. Now, I just assume if this is a real statistic in the data and a rule-based system had learned it, well, the neural net, which was the most accurate model on the data, must have learned it as well. And you might think that's why we were afraid to use the neural net. Not exactly. We kind of thought, if we now know that there's this asthma problem in the neural net, we can probably find it and fix it and make the neural net safe for asthmatics. What we were really concerned about is what else might the neural net have learned that's similarly risky, like this asthma pattern. But because we don't know it's there, we don't know we have other things we need to fix. Before I go on and tell you how we're going to solve this problem, I just want to say this is a confounding statistical issue. These are proxy effects. It's happening in all data sets. Every medical data set you have ever worked with has these problems in it. It's just that if you're not using interpretable machine learning, you're not seeing these problems. So it's a ubiquitous problem. And even features that we won't know about for 10, 20, 30 years, like our genome's not in our medical records yet for most of us. Even those features can cause confounding on current features. So it's not like you can wish away the problem and say, oh, I'll just collect all of the appropriate features, because some of the appropriate features won't even be available in the future. And medicine has typically tried to get around this problem by doing randomized clinical trials. The problem is it's not ethical for us to do an RCT to sort of withhold rapid high quality care for some asthmatics in order to train a more accurate neural net. So we have to learn to live with the data the way it is. You might think you could detect these problems in the raw data and then clean the data. It turns out, for reasons that hopefully you'll see in a few minutes, that's actually harder to do. Understanding the model, surprisingly, is easier than understanding the data. And although we won't talk about it that much today, it turns out the same methods we're going to use to detect and fix this asthma problem works for detecting race bias, gender bias, socioeconomic bias in data. Okay. One solution to this would be to have a model as accurate as that neural net we wanted to use, but as intelligible as rules or logistic regression. But you might have heard that there's this trade-off between intelligibility and accuracy. The most accurate models, things like deep neural nets and boosted trees, aren't very intelligible, and more intelligible models like logistic and linear regression sadly aren't as accurate as we would like on complex data. The good news is that at least if we're talking about tabular data, which a lot of clinical data is in healthcare, it turns out that this is just no longer true, that you have to suffer this trade-off. We now have a method called EBMs, explainable boosting machines, which are as accurate on tabular data as deep neural nets and boosted trees and random forests, but it turns out even more interpretable than things like logistic and linear regression. So here's an example of an experiment we've done. Careful, I'm a co-author of this, so take the results with a grain of salt. Here's 10 different data sets. Here's EBMs in the first column, and the average ROC is 0.866. And on this data set, it turned out the most accurate black box model turned out to be gradient boosted trees, which is this last column. And here you'll see that the average accuracy is also 0.866. So it turns out that we're about as accurate on average as full complexity models here. Now, here's a study we weren't involved in. This is Cynthia Rudin and her colleagues at Duke. And they looked at a number of glass box models, and all the little arrows point to us, EBMs, using our open source package. And it turned out we were the most accurate of the glass box methods. And then they observed in their work, just as we've observed, that the best glass box models, in this case us, perform about as well as the best black box models on tabular data. And then I won't talk about it today, but we also have a collaboration with some people at Google and with Jeff Hinton at Toronto and Google, where we're training these EBMs. We're training them now with neural nets as well. So if you're into neural nets as opposed to gradient boosted trees, it turns out you can get these same sort of models out of neural nets, and that gives some additional flexibility. But I'm not going to talk about neural nets anymore. Okay, let me tell you what these EBMs are. So this is what linear logistic regression looks like. You know, it's either a straight line or a straight line passed through a logistic. Very interpretable, not always very accurate. It can't model nonlinearities. It has a lot of trouble with things like fever, you know, where normal body temperature is in the middle. And if you're hypothermic or feverish, you know, you're at higher risk. Like it can't model that unless you do some feature engineering. And sometimes it even gets the sign wrong on variables. There's a tendency to look at signs positive or negative as being very important in linear logistic regression. But because it can't model the data, we see often that it gets the sign wrong. So you shouldn't even trust the sign of linear and logistic regression. Now on the right, we've got full complexity, deep neural nets, random forest, boosted trees. These are black boxes, not interpretable, of course. They can be very accurate. They can easily model nonlinearities. They can easily model things like normal behavior is in the middle with higher risk at either end. However, they are a little more likely to learn spurious effects. And I won't talk about that more, but it's a very interesting issue. In the middle, there's these generalized additive models, of which EBMs is one example. And these are even more interpretable, it turns out, than linear and logistic regression. And that's because you can actually understand the curve. Doctors look at this curve and it makes more sense to them than a straight line. These can be just as accurate as these black box models. They can model nonlinearities, normal in the middle, and they're more likely to show important effects. So let me give you an example from pneumonia. This data set has 46 features. Each of these features is going to become a graph. So we're going to have 46 graphs. So we're going to have 46 graphs like this. You find the patient's value on the x-axis. You read off the contribution to risk on the y-axis, and that gives you a number. And these numbers are like log odds. The more negative the number, the more it lowers the risk. The more positive the number, the more it increases risk. So if we're doing logistic regression, we'd be doing 1 over 1 plus e to the minus score, which is the sum of numbers coming from all these graphs. Now, if this was a linear model, each of these graphs would just look like a straight line, and we probably wouldn't even plot the graph. We would just give you the coefficients. And then this exponent would just look like a linear model, you know, beta 0 plus beta 1, x1, beta 2, x2. But instead, our score is going to come from these nonlinear graphs. So this exponent is now going to look like a sum of the numbers that are coming from these graphs. And if, for example, the sum of scores from all of those graphs was minus 0.78, put it through the logistic function, you would get, in this case, a probability of death of about 30%, which of course is very high for many conditions. Now, here's what the model learns about risk as a function of age. At the same time, it's learning about risk as a function of all the other 45 features. So let me read this graph for you. So down is low risk, high is higher risk. It's good to be young. Young is anything under 50. The model doesn't seem to distinguish between people in their 20s, 30s, and 40s. It just says they're all equally low risk, even though it could distinguish between them if it needed to. Risk goes up slowly as you go through your 50s into your 60s, rises pretty rapidly around 67, 68, 69. That's a retirement effect. We see this for many conditions in the United States. Retirement has a big impact on your healthcare payer, possibly your healthcare provider. You may have moved to a new part of the country. You may have delays in getting to healthcare. So we often see this retirement effect. Risk goes up very rapidly as you go through your 70s into your 80s. Risk rises rapidly right at 85, a very round number, surprisingly flat through the upper 80s and 90s, and then it drops at another round number, 100, 101. The rise in risk at 85, from talking with doctors, it's nothing in healthcare policy. We believe what's happening is doctors are saying, you know, the patients over 85, they're really very elderly. The first round of treatment did not help the patient's pneumonia. Perhaps we're not helping the patient by fighting too hard here. The patient already has a number of comorbidities that have caused them to get pneumonia. Perhaps we're not helping the patient by being too aggressive in our treatment here. So doctors seem to accept that that's an explanation, and that 85 is a sort of round number where they often distinguish very elderly patients from somewhat less elderly patients. Very similar thing is happening here at 100. When you've got a treatable illness like pneumonia, doctors just don't want to give up on a patient if they've made it to being a centenarian. They want to go for the record. And because of this, we see that this extra vigilance in care does make a difference and lowers the risk of patients this old. Interesting thing about this model, it has many graphs like this that I can't show you. This is the most accurate model we can train on the data. So we get all of this detailed understanding of how the model works. And we get this without any loss of accuracy. This is, in fact, the most accurate model on this data set. Now, if you're a doctor, you probably don't want the model to predict that a person who's 105 is lower risk than someone who's 95. So this model, because it is a series of graphs, can be edited. And we're actually building an editor. It's kind of like a Photoshop for healthcare, which enables doctors to look at these graphs and when they need to edit the graphs. Now, if you're an insurance company, you just want to know how the world works. So you wouldn't want to edit these models. So that's very important. It turns out that the correctness and accuracy of the model depends on what you're going to use it for. Let me show you some things it learns. Jumps at round numbers are always due to human social policy effects. There aren't phase changes that happen that much in biology. It does learn that asthma lowers risk. It learns that heart disease also lowers risk, even more than asthma. And it learns that having a kind of wheezing called stridor, which indicates you have an obstructed airway, also lowers risk. None of these things are true. All of these things increase risk. And yet the model learns that these things lower risk because, for example, the heart disease patients get to the hospital very, very quickly because they're afraid they might be having a heart attack. They don't know they have pneumonia. And the stridor patients can't ignore their wheezing and they also get to care. Now, if doctors want, we can just zero out this so that these effects go away. Or if a doctor tells us to, we can actually make each of these things appear to be extra high risk. And what's really sad is if you left the model this way, it's additive. It means that a 105-year-old with a history of asthma, heart disease, and who now has an obstructed lungway would be predicted as extremely low risk, which of course is not true. And the model is predicted with, it's rewarded with extra high accuracy for predicting those things. And that's because the test set looks just like the training set. So it's good we didn't deploy the neural net because it probably had these effects sitting in it, but these new intelligible models are just as accurate and we can see these problems. And it's important, you have to keep these features in the model. You might think you could remove heart disease from the model and that would correct the model. Because of correlation, it doesn't. I want to show you there are some beautiful things we learn from these interpretable models. This is pneumonia risk as a function of your blood urea nitrogen. And what you can see here is that at 50, the risk goes flat. And that's because doctors start to give a medication at 50 and it's effective. At 100, notice that the risk peaks and then starts to go down, which is really crazy that your risk would go down as your blood urea nitrogen goes up. This is also a treatment effect. Patients start to receive dialysis typically once their blood urea nitrogen has broken 100. So doctors were excited that they could see this, but they were also concerned. They saw that risk was already very high at 40, and they thought maybe they shouldn't wait till 50 to give this med. It's a very safe med, so maybe they should be giving it at 40. And they thought it was sort of tragic that patients who have a blend of 120 are lower risk than patients at 90. So they wondered if they shouldn't move this treatment threshold to 90 or 85. And we can actually use this model as a kind of what if spreadsheet. And we can estimate conservatively that if we were to move this treatment threshold to 85, then we would get a graph that's no worse than this red line. I won't explain the detail of why we think that. And then the area between the red line and the original line, which is the original treatment threshold and protocol, is lives saved. And the estimate is that you're just changing this one treatment threshold for one condition, pneumonia, for one lab test, blood urea nitrogen, that we would save more than 2,500 lives in the United States alone, which is only about 3% of the world's population. So by the way, one sign that the original treatment thresholds couldn't have been optimal is that they were at 50 and 100. What are the odds that two round numbers like 50 and 100 are optimal? We see these treatment thresholds all over the place in data. Here's a systolic blood pressure. Notice risk goes up to about 175, comes down, up to about 200, comes down, up to about 225, comes down. It is not the case that having higher blood pressure can be good for you. It's just that you're hitting different treatment thresholds and these treatments are effective. Let me show you an interaction between two features. This is whether patients have or do not have cancer on the bottom. The patients with cancer are on the right. This is age on the vertical axis. And the group that's of interest is this a yellow group who are very young patients who have cancer. Notice that this is adding 0.5 to their risks. On a log scale, that's actually quite a bit. And what's happening is these are patients who are cancer patients who are young. They're being treated extra aggressively for their cancer because young patients can handle a more aggressive treatment. And because of that, their immune system has been knocked out. They have pneumonia or they wouldn't be in this data set. And basically the model is recognizing that extra young patients can be at very high risk from pneumonia if they have cancer. And then doctors explain this to us by saying it's actually the aggressive treatment that these young patients receive. So let me brief, sure. Do I have 1 minute or shall I just stop?
You can wrap up 1 minute.
Sure. This is ICU mortality. Here's PF ratio. This is how well you're breathing. High-risk patients are not breathing well. Low-risk patients are breathing well. There's a very surprising dip happening right here. It turns out that dip is not due to a round number. It's because missing values in this data set had been imputed with the mean before we got it. And we have a large number of very healthy patients here. It turns out most of these patients who are missing this value are missing the value because they were healthy. They did a pinch test and didn't bother to measure the lab test. And it turns out you have to be able to detect this and fix this because either, like the model's pretty accurate for the patients who are missing the values because it comes down to very low risk. The problem is there are real patients who have this PF ratio and they're going to be predicted as being low risk as well when in fact they're not. Okay, I'm going to skip the severe maternal morbidity. I'm going to skip the COVID-19. And I will skip the cancer treatment. And I'm just going to go to a summary. So high accuracy on a mission critical domain like healthcare, accuracy is not true north. It is easy to get high accuracy because the models are doing the wrong things. And once you have an interpretable model and can see what these models are doing, it's amazing how many surprises you will find. The data is always interesting in ways that you can't anticipate. Although sometimes it's really obvious afterwards. These new kinds of models really give us an amazing combination of accuracy, intelligibility, and editability. And you really need these glass box methods to see what's going on in your healthcare models. Otherwise, they are putting certain kinds of patients at risk and you don't know it. And we've now built an editor for these sorts of models that doctors who have started using it say that they will not use any machine learning method for which they cannot see and edit the model going forward. Okay, I just want to say thank you. And sorry, I went over a few minutes.
Thank you, Rick. Thank you for your presentation. If you can stop, so great. And so next, Jana Wins, who is at the University of Michigan.
Great, thank you so much. And thanks for inviting me to come and speak on this panel today. So in my research group, we develop and we use machine learning techniques to identify patterns in all the data that we're collecting in hospitals today. And we use these patterns to predict risk for patients, risk of a particular adverse outcome or event, or to match patients to appropriate treatments with the ultimate goal of augmenting clinical care and improving patient outcomes. And given the challenges that today's healthcare systems are facing, there's a critical need for this kind of clinical decision support. But I want to emphasize that our goal here is not to replace physicians. We want to augment physicians. And it's important to remember that augmentation really works both ways. We know that models are error prone, and moreover, rarely can they perfectly capture all the nuances of a complex clinical situation. And this is where humans come in and where they can help. So in today's talk, I'm going to give you two examples of how models can fail and how physicians can help. And the first example relates to a problem in which we've been able to make considerable progress, and that's patient risk stratification for infection with Clostridioides difficile, or C. diff. So this pathogen is a bacteria that takes over the gut when normal flora get wiped out, and it's associated with excess medical costs of billions of dollars per year in the US. And we hypothesize that one of the reasons this bug remains so stubbornly prevalent is that we lack an effective tool for measuring patient risk. So given that the risk factors are multifactorial, we take a data-centric approach to the problem, leveraging the contents of the electronic health record to learn accurate models for predicting who's going to acquire one of these infections during their hospital stay. And within the EHR, we have everything from what medication a patient is taking to where they are in the hospital to who's in the bed next to them. And we use these data as input to a machine learning model, in this case, a linear model, predicting a patient's daily risk of acquiring an infection during the current hospital visit, and applied to validation data from two large hospitals in the US, the University of Michigan hospitals on the left here, and the Massachusetts General Hospital in Boston on the right. Our approach achieves good discriminative performance, and more importantly, was able to identify cases well in advance of clinical diagnosis. So it took a lot of work to get to this point, but knowing how well the model will do on one held out year wasn't necessarily enough. We wanted a model that works well, not just on the test data, not just next year or the year after, but for many years to come. In short, we want a model that's robust to small changes in healthcare or large changes, like during a pandemic. So here I'm showing the model's performance on a monthly basis, so pre-COVID in red, and during COVID in blue. And aside from a drop in performance in April, the model was surprisingly robust to the very real, very large changes in patient populations and clinical protocols observed during the pandemic. So to achieve such robustness, researchers often focus on models that are simple, in which the average complexity of rules is low. In our work, we're using linear models here. But oftentimes researchers will go a step further and they'll look for a model in which the number of variables included is small, with the assumption that if the model depends on fewer variables in simpler ways, then fewer things can go wrong. But this isn't necessarily the right thing to do. Let me explain why. So to decrease the size of a rule set, people will often use regularization techniques like L2 on the left or L1 on the right. And we know that L1, lasso in particular, encourages sparsity in the set of parameters, making it perhaps an attractive choice when trying to reduce the size of the input feature space. But with two perfectly correlated features, L1 can randomly choose one, either X1 or X2, eliminating one from the model. And this reduces the size of the model or the number of features on which the model depends, but it doesn't necessarily lead to a more robust model. So, for example, given a linear model, we can sort the features by their learn coefficient to try to understand how the model is making its predictions. But this is where things can get funky. So we see the top weight here is CDI diagnosis in the past year, which makes sense. Patients who have had C. diff in the past are a high risk of reinfection. But we don't have to go too far down to the list until we come across this weird looking variable, vitamin B. So this might show up here simply because it's highly correlated with another risk factor that was eliminated. So this is the type of proxy that Rich was talking about in his talk. And by relying on these spurious correlations, the model is more susceptible to changes in clinical practice. But we know that there are certain factors that increase the risk of disease. The problem is the model doesn't. So in our work, we sought to develop methods that could incorporate this knowledge about what does increase the risk of disease without sacrificing model performance. Essentially, if two variables are highly correlated and we know that one variable is causally related to the outcome, we want to encourage the model to incorporate that variable and not the other. So we incorporate expert knowledge regarding what is known to cause an increase in patient risk in the form of a new regularization term called the I penalty. And we call it the I penalty because of the shape of its contour plot. So for every input variable, we include a binary flag indicating whether or not the feature is known to lead to an increased risk of infection. The details are in our KDD paper, but essentially given information about what is a known risk factor, the model favors a solution that's dense in the set of known correlated features and sparse in the set of unknown correlated features. So going back to the task of predicting CDI, we identified known risk factors based on the clinical literature, things like antimicrobials that put you at higher risk because they wipe out the gut flora. And we measured how often the known risk factors appeared near the top of the ranked list, so where the model was using those features. And we did that using the average precision. So the first row in this table represents the case where only known risk factors are used to train the model. And in this case, we trivially achieve an average precision of 1, but we observe a significant drop in the discriminative performance, the area under the curve of the model. A trade-off we might not be willing to make. And this is where the I penalty comes in. And compared to other common regularization techniques including weighted lasso, which incorporates information about which factors are known, I led to higher precision and without trading off the area under the curve or the discriminative performance of the model. So in summary, we have shown that using the I penalty results in a model of near identical discriminative performance, but one that depends more on known risk factors. And this leads to not only a model that's more robust, since in high dimensional settings, correlations are fragile and they can break over time. So you're better off including known causal factors than some features, say, based on possibly a spurious correlation. But what about if your input space is something like the raw pixel values of an image where we can't apply such regularization terms? So this brings me to the next part of the talk, the second example. So let's consider the problem of diagnosing patients who present with acute respiratory failure. And there are several underlying causes, but the most common ones include heart failure, pneumonia, and chronic obstructive pulmonary disorder, or COPD. This is a challenging clinical problem. In up to 30% of cases, patients may receive incorrect treatments, and this can lead to harm. So tools that could help clinicians in making diagnoses could ultimately improve outcomes. So we set out to use deep learning applied to chest x-rays to develop a model to predict the probability of each of these diagnoses. Our study population consisted of nearly 1,300 patients from U of M who developed acute hypoxic respiratory failure. And each patient admission was reviewed independently by at least 2 physicians and assessed on a scale of 1 to 4 for each of the 3 diagnoses. And these scores were then averaged and thresholded to produce binary labels for training and evaluation. But early on in the project, the models we were training were doing really well, too well. So when we looked at what aspects of the chest x-ray the model was using to make its diagnosis, and we sat down with our collaborators in intensive care and radiology, things looked weird. The model was picking up on things like breast tissue, bone structure, feeding tubes, not clinically relevant radiological findings. And that's the problem. The problem with AI is that, well, it's powerful, it's susceptible to biases and shortcuts. If in your training data, there's a strong correlation between, say, being female and having a specific diagnosis, then the model can learn to exploit that shortcut. And while this might work well for the training data, it's not clinically meaningful and can fail to generalize if the relationship doesn't hold in the deployment environment. And this has been recognized in other tasks not related to healthcare. If you have a model that's trained to recognize, say, cows, it can fail when the cow shows up in a completely unexpected place, because instead of learning what makes a cow, the model has learned to rely on a shortcut related to the green background. And this presents a serious issue in healthcare, since models can perpetuate or even exacerbate human biases in clinical care. So in the context of learning to diagnose based on chest x-rays, we sought to identify potential shortcuts and characterize the ease with which models could learn to exploit these shortcuts when making diagnostic predictions. And this is work that we presented this year or last year at MLHC. So first we looked at how easy it was to say learn whether or not a patient was female based on a chest x-ray. If this is a very challenging task, then it's not really a shortcut. But we showed that from a chest x-ray alone, a DenseNet can identify female patients with near perfect discriminative performance. And this holds not only in our smaller cohort, but also in larger cohorts from Mimic and Chexpert. Beyond male versus female, we found that deep learning models can learn to map chest x-rays to a number of potentially sensitive attributes, including age, body mass index, and even race. So when these attributes are correlated with the outcome of interest, a model can use them as shortcuts in its prediction. And this creates a problem when transferring models across institutions where demographics might shift. The potential of shortcuts related to sensitive attributes could also lead to bias amplification, in which human biases are not just replicated, but actually amplified by a model. So to mitigate shortcut learning, we developed an approach based on transfer learning. In short, we want to encourage the model to rely on clinically relevant features that are more likely to generalize across populations. We were inspired by the way in which a clinician reuses common radiological features when diagnosing disease. In our setup, we aim to solve a target task. So for example, diagnosing congestive heart failure, but we have only a small, potentially very biased training set. If we leverage this training set, we'll almost certainly learn shortcuts and fail to generalize. So we also assume access to some related but curated source task data set that shares similar features, in this case, diagnosing pneumonia. Our approach is two-stage. We first learn a model, in this case, a DenseNet, composed of an encoder E and a linear layer F on the source task. And this results in model parameters theta and W. And in the second stage, we freeze all of the encoder parameters, essentially extracting features from the images, and retrain the output layer on the target task, which remember is highly skewed. Though simple, such an approach proves surprisingly effective. Assuming a target task of CHF in which there's a strong correlation with age, simply training on the target task without first training on the source task does significantly worse compared to user transfer learning. And we found this held across different sources of bias. And while transfer learning is a well-explored area, it's a surprising result that the last layer simultaneously has the capacity to learn an expressive model, while also not enough capacity to overfit to the bias. And you can find the full results in our MLHC paper, and the code is available on our GitLab. So takeaways. I presented two examples in which machine learning in healthcare can behave strangely due to the presence of spurious correlations or shortcuts. In the first setting, in which we were using linear models on EHR data, we showed how a regularization technique that incorporated domain knowledge about risk factors could lead to a more robust model while maintaining discriminative performance. In the second example, we demonstrated how deep learning models applied to chest x-rays can easily take shortcuts related to demographics, if present. But to mitigate this, we leveraged a related curated source task and a simple transfer learning technique. So the approaches I've shown you here are computational. They're computational to improving robustness. We're now looking into human-based strategies, measuring to what extent humans themselves can pick up on the bias models that are erroneously relying on shortcuts. And I think it's this kind of collaboration that will be most effective in improving the generalizability of models across populations and institutions. So to find out more or access any of our publications or code that I cited in this talk, you can visit my group's website. Thank you.
Thank you very much, Jenna, for an excellent presentation. And I would like to thank you all for also for being on time, in addition to giving excellent presentations. So I think what we will do now is we'll move to a panel discussion, having all three of you involved. And I'll start with some questions, and also we'll be looking at Q&A to answer any questions that may come in. So one issue that I think Rick covered, and I think both Emma and Jenna alluded to, is this issue of interpretability of AI and the ML models. And I guess Rick's argument is that there is no price to this interpretability, at least when we are dealing with tabular data. However, when we're dealing with images, or even if we're dealing with voice, digital recording of voice, or even text, then in those cases, I believe that deep learning models are probably the way to go. The question is there a price to interpretability? Is there, in instances where more interpretable models cannot necessarily lead to the best possible performance, what is the right trade-off between performance and interpretability? And anyone who wants to jump in, feel free to do so.
So I'm happy to jump in first. I think if you're thinking about this as a trade-off, you're thinking about it in the wrong way. I think interpretability, or at the very least, digging in to what your model has learned, is so essential to the generalizability and performance of any model. So in the work that we're doing with chest x-rays, we're using a DenseNet, a deep learning model, but we still looked at what the model was learning at the end of the day through looking at the activations. And if we had deployed that model, I mean, it would have been the same story as Rich was telling back in 1995, but today in 2021, and the model would have failed miserably. So I think I don't think it's a trade-off. I really think it's essential, but I'm curious to hear what Emma and Rich think.
I very much agree that digging into how the model is doing what it's doing is essential. I mean, certainly in the knee pain work I presented, we spent a lot more time trying to figure out what the model was doing, and that it wasn't concerning than we did generating the main results. So I 100% agree with that. Because that is sort of, at least from my standpoint, intrinsically more difficult with neural nets than with more interpretable models, my strong preference is to use simple interpretable models. And this is what I teach my students as well, unless I'm in a domain where it's clear that neural nets are state of the art. Like, you can't fit a linear regression on images, and no one would try. And I guess the final thing I would say, based on my own experience trying to interpret neural nets, is the state of the art is not adequate if we're really to understand what these models are doing on medical images. I mean, I think, results like what Jenna was pointing out, and other sort of recent papers showing, we can predict race from medical images, and the authors don't really understand why. It's very unsettling to me, I guess, and suggests to me that we need to make fundamental advances there.
Hey, so my experience is that machine learning models, about 80% of what they learn is exactly what we hope they would learn. About 10% of what they learn is downright dangerous for certain classes of patients. And maybe another 10% of what they learn is actually interesting, new, and surprising science. So if you don't have intelligibility, you're really missing 20% of the importance of the model, especially the part of the model that would put patients at risk. And here's what's annoying, which is you're most likely to put patients at risk for whom we have accepted high-performing treatments. And that's because the treatment effects show up in the model. So, and if you've got a very effective treatment, it's very easy for the model to learn that someone is low risk, when in fact they're high risk. And the only reason they're low risk is because there's an effective treatment. And that's really tragic if our models are going to sort of go out there and say that the patients that are the ones we currently know best how to treat are in fact low risk, and maybe that would then deny them the kind of care that we know how to give them already. Completely agree though with everything Jenna and Emma said. In images, as you said, Yanis, in images, to some extent in text, in acoustics, deep neural nets are the state of the art, and you're not going to get away with something like a generalized additive model like we're using on tabular data. So you definitely are going to have to use all of the methods that are slowly being developed for trying to understand what's happening inside of images and deep neural nets, just like Jenna was showing you. But you have to do it. And I mean, you just absolutely have to do it. Otherwise, your model, I guarantee you, is putting certain kinds of patients at risk. And that's a terrible thing. Machine learning should not be putting some patients at risk while perhaps helping other patients. And once you can understand what the models are doing, it's amazing how often you'll be surprised.
Thank you. So let me move you to another topic. So we talked a little bit about robustness, and Jane actually talked quite a bit about robustness of different models. There is one argument, I guess, that Jenna made is that you have to use the right regularizer in order to end up with an appropriately robust model. There is some recent work, and I have been involved in some of this work that sort of has developed a framework that given a robust formulation of the original learning problem, then you can show that the problem reduces to a regularized version of an empirical risk minimization problem, with the regularizer being derived depending on sort of the assumptions that you make for the specific model. Another sort of issue that was brought up is in also the Q&A is sort of this issue of algorithmic security. So sometimes robustness may not necessarily be because of outliers that may exist either in the training set or in the test set, but there may be sort of adversarial inputs that may potentially contaminate your training set or even contaminate your test set. As we know, algorithms can be attacked. So is that an issue? And then your thoughts on potentially adversarial training of some of the models to address these issues with adversarial attacks?
I can start a little bit. One of the values of intelligibility is that certain kinds of adversarial attacks can be easily detected. There are other kinds, if the adversarial attack was very, very clever, and if they knew you were using a certain kind of interpretability, then they might be able to fly under the radar. But it greatly constrains what they can do and what kind of attack and the degree of the attack to be non-detectable through to interpretable methods. For privacy issues, which we haven't really talked about, we are able to do differential privacy with generalized additive models and things like that. And it's one of the best ways to get differential privacy is through simple models like GAMs. Yeah, let me stop there and let the other speakers say something.
So I think adversarial attacks are always a concern. But in terms of model robustness, I think that the very real concern, immediate concern, are distributional shifts in patient populations in clinical care, like we saw during the pandemic. Even when the pandemic first started, we were looking at training models, and the patient populations that were effective in the first wave were different than the patient populations that were affected in the second wave and the third. So having that robustness to the shifts in patient population, making sure the model works across different age groups, different races, different ethnicities, different genders, different geographic locations. I think that that's still a problem that we haven't necessarily solved. So I think we have to work on both the adversarial attacks and the distributional shifts that are occurring right now in healthcare at the same time.
Yeah, perhaps I'm about to make a lot of adversarial people adversarial, but I tend to think that of the two issues, like adversarial examples versus distribution shifts, like I've seen a lot more instances of the latter being a problem in the real world. Like perhaps this is just my ignorance, but I don't know. It's sort of a case where like adversarial examples and like deliberately malignantly generated adversarial examples were a problem in a healthcare application. In contrast, distribution shifts seem to be a pretty ubiquitous problem in healthcare deployments. And it's like it's not just a theoretical concern. It's like a very it's a very concrete concern, and it's clear that this is an area where more research is pressingly needed and more robust methods are pressingly needed.
And Jenna Jenna, by the way, did some research, so this goes back more than 5 years, I guess now, where they basically used inductive transfer to train a model for multiple hospitals. So instead of just pooling the data from many different hospitals and assuming that the hospitals are all somehow the same, instead, Jenna used inductive transfer to train a model across multiple hospitals. And that way the model could be specialized to hospitals as necessary, but also could benefit from what was being learned from the data from other hospitals as well. And I think that's one good approach to creating robustness in the face of geographic and institutional differences.
Yeah, I think it depends a little bit on the task or the outcome, but in that work, it was healthcare associated infection. So even the layout of the hospital can have an effect on how disease is transmitted in a hospital. And if you don't account for that, then you're going to miss out on some of the potential predictive performance of a model. Thanks, Rich.
Let me take you to a slightly different topic. So I think in the panel earlier today, there was a lot of discussion about bias. In Rick's presentation, there was some instance of the bias where essentially you have different treatment selections that may lead to a biased model because the treatment selection reflects the judgment of the physicians that make decisions, and the models are fairly smart enough to pick up on those types of decisions. So you may end up with a biased model just because you are looking at these types of specific outcomes that are incorporated into the model. So in general, one potential argument is that we may need better data and we may need richer data sets so that we can avoid some biases of this type, and also other types of biases in terms of race, in terms of ethnicity, in terms of socioeconomic status. So what are your thoughts on either methods that can mitigate the bias, or even think about data governance issues that potentially may help collect data from less well-resourced settings and to some extent help mitigate some of the biases?
Yeah,
So no, go ahead, Emma.
Okay, sure. Yeah, thanks. Yeah, I mean, I think incentivizing better data collection is crucial. I mean, certainly the area I focus on is particularly sort of race, gender, socioeconomic, and other biases. And our work has empirically demonstrated that if you train your model on a racially diverse data set, you get generalizable performance than if you don't. And of course, there are other demonstrations of that as well. We've seen in genomics, for example, that you train these genetic models on people of predominantly European ancestry, and they fail to generalize to people of other ancestries, right? And while methodologically you can do things to mitigate that, I tend to think that also there is no really getting around the fact that we need better data collection, and that would include both collecting data on more representative cohorts. I think it also includes even just tracking the data you need to assess when performance suffers across different groups. For example, race itself can be sort of inconsistently recorded or collected in EHR data, which can really blind you to the fact that your models are even performing badly on other groups as well. In terms of how to incentivize this, I mean, I think, certainly as an academic, we respond to publishing incentives. Like if you can't publish your work unless you're using sort of, diverse data sets that are actually representative and reporting sort of the characteristics of the data you're using, if we start to make it unacceptable to sort of publish stuff unless you show that things are generalizable, then people will respond to those incentives. If we reward people with citations for publishing sort of publicly available data sets that are actually representative, people will create those data sets. And, I perhaps this is overly cynical, but I tend to think that people respond to professional incentives. And so, we need to set that up in terms of publication in academia, and more broadly, we need to set it up in terms of regulation. Like if you can't deploy your algorithm unless you've sort of shown how it performs across different populations, people will show how it performs across different populations.
Hey, so that's part of what I was going to say, in fact, is that you always would want better data, more diverse data, and having incentives to cause people to collect it because it's not easy to collect is wonderful. However, you will never have ideal data. And often when I give the presentations like the one I did today and I show defects in what the model learns, people say, oh, well, you just need to collect better data. You need to go get those features that you're missing in the data set and make sure they're in the data set. And if you're seeing this effect, at age, well, then you need to collect data. And what I point out is, well, first of all, twofold. Well, the only reason we know that the data was missing certain features is because we trained an intelligible model on the data. We could understand weird things in that model, and then that led us to recognize what might be missing from the data. So you can't sort of assume you're going to have the perfect data and wait until you get it. For example, with asthma and pneumonia, you'll never be allowed to have the RCT data. It's not ethical to ever run the experiments that you would have to run because we already know how to treat people with pneumonia and people with asthma. So you're never actually going to have the right data. All data will have these treatment biases in it. All data everywhere will always have these treatment effects in it. You will never be allowed to collect the data that you would want. So it's really important that your methods can, one, show you what a model is learning from the data. And that's because there are these surprising gotchas in every data set. And that's just the way it's always going to be. And then the models we're working with are editable, which means that you actually can go in and you can say, the reason for this jump in the graph at this point is because of this effect. That's very interesting to see, but we don't want, given that we're going to use the model clinically to decide who should or should not get a treatment, we don't want the model to already be taking the treatment into account. Therefore, we want to edit the model at this place. And some people say, well, that's terrible. You can't edit a model and overrule the statistics in the data. But if you actually understand that the statistics of the data reflect treatments, and you need a prediction that's prior to the treatment or independent of the treatment, well, you have no choice. You will not be allowed to collect the data without the treatments. It's not ethical. You can't decide, oh, well, we just won't work on this problem because that, almost all problems have treatments being given. So you really have this conundrum where you just have to work with the data that you've got. And if the model is correctable by doctors, that makes a huge difference in your ability to safely deploy a model.
So
let me just add, in terms of recruiting diverse populations, I just wanted to underline something Rich said, which is it's not easy, but we have to do it. It is so important. And incentives are important, but they're also not enough. We need partnerships. Here at Michigan Medicine, even if we manage to recruit all 4 million patients that we've seen over the last decade, we'd still only have 2 to 3% of the population identifying as Hispanic. We need to partner with other institutions to be able to recruit a population that's reflective of our nation and our world. And it's going to take a lot of effort, and we have to work together and do it.
And if I can expand a little bit the question, if you think beyond electronic health records, if you think about other forms of data that may be coming from apps, that may be coming from medical sensors, do you think that the ownership regulations regarding the data have an effect on the quality of the data? So, for instance, one argument could be that if the data are owned by the companies who own the hardware and are collecting the data, and maybe there is a cost associated with these types of devices, then this may be more suited to more well-resourced settings and you'll end up with much less data from less well-resourced settings. So if we think about data ownership regulations in the US versus the EU, do you think this has an impact on the quality and the representative features of the data that are being collected?
I'll just say briefly that I think it is unfortunate that in the United States, at least, it tends to be that hospitals and doctors own your data and that it's not publicly accessible for research for the most part, with a few exceptions. And other countries are quite different. For example, the UK, which has a more socialized healthcare system, has a belief that the entire country's medical records should be available for careful medical research, and that gives them a definite advantage. And if we start to see, as you suggested, Yanis, as expensive devices come online, that the data from those devices is owned by the company that creates the devices, that would be unfortunate too. I know, for example, that at least one company that creates a glucose monitor, they're the ones who, with the patient's permission, own the data from the patient. And that data is probably not easily available for research. So this is unfortunate. And sometimes there are massive data sets out there. For example, we occasionally work with Epic, which is the largest medical record system used in the US. And they'll have a wonderful data set. But because of the agreement that they have with their customers, with hospitals, they're not able really to make that data available to researchers, except with a few rare exceptions. So it really is a challenge.
Yeah, I think that there's definitely a balance between autonomy and diversity in recruitment. At Michigan, we have a very explicit consent process for our Michigan Genomics Initiative, where we collect health data in addition to genomic data on individuals. And that population is whiter and older than even the population within Michigan medicine, because of a number of issues related to consent and the likelihood of certain populations agreeing to consent. And we have to do more to reach out to these communities to, again, going back to developing more diverse populations and data sets. It will take time and effort. There's no easy fix here.
I guess I could just say, I mean, yeah, obviously the obstacles to data sharing in the United States are like a formidable impediment to medical research. They restrict the people who can do medical research to people at sort of historically elite institutions with access to medical data, and that's also a problem in terms of what we research. And my sense is that, like, basically that restriction occurs, in part for good reasons, like patient privacy, et cetera. And in part for bad reasons, like hospital profit motives and the fact that data is valuable and they don't want to share it. And, I have very little patience for the latter. I mean, I think it's profoundly hypocritical to be an institution that claims to be in the business of saving lives. I think it's profoundly hypocritical to say that you're a nonprofit and then to refuse to share data when it has the ability to dramatically accelerate medical research. And perhaps this is just me being young and naive, but to the extent that it's possible to say no, you can't do that if you're going to be a nonprofit. If you're going to claim to be acting in the public interest, then you're not allowed to just hog your data because it's a valuable resource. I don't know. I would support such regulation.
By the way, this is one of the reasons why we're doing research now on differential privacy in interpretable models and federation with the interpretable models as well, is we're trying to get rid of. It's very easy for a hospital to say, like, well, look, we have to protect the privacy of our patients, therefore you can't have the data. But if things like differential privacy and federation are working better and become accepted, practices that guarantee protect privacy and things like that, then at least that obstacle will go away. And hopefully we'll see more groups that are sort of willing to share their data because there will be guarantees of privacy.
So another question that came through Q&A is that how do we test models for the presence of bias? So what if we don't necessarily are not able to measure the confounding variable? Any thoughts on that topic?
Rigorous testing across diverse populations. I mean, I think it keeps coming back to that, right? Even if you don't have that data for training, at least have that data for testing, right? I would never deploy a model that I haven't tested on a diverse population, especially if I plan to deploy it in a diverse population. I think that's really critical.
I totally agree with that. I think another thing to keep in mind is sort of, is the target variable that your model is trained to predict, is that in fact the variable that you want to be predicting? Because the problem is if your target variable is off, so like recent high profile example, right? Algorithm trained to predict cost, patient cost is a proxy for health. Turns out that patient cost is not a great proxy for health because there are systematic sort of racial disparities in how much money are spent on people who are equivalently sick, right? So the proxy variable is bad, the target is bad. This is like a very frequent thing in medical and other settings. And, it's particularly insidious because you can't detect it just by looking at the fitted model, right? You're like, oh, we predict cost equally well across racial populations. Fantastic, we're good to go. And it's like, no, like there's a fundamental conceptual issue. And so this sort of requires careful thought and domain-specific knowledge about, is what you're targeting really the thing that you want to be predicting?
Hey, when the EU was first drafting the GDPR regulations, they were seriously considering making sensitive variables like race, gender, possibly age, protected variables, and that it would require, let's say, an extraordinary reason to have access to those variables. And we were invited to go out and talk with them because our work has shown that if you hide a variable like race or gender, just as Jenna's work showed, it doesn't mean the model can't can't depend on race and gender. It can often learn this from the other information that it has. And we basically explained to the EU, to the regulators, that it's not quite as easy as you might think, that hiding a variable does not mean that the bias with respect to that variable goes away. It just means that it becomes more entrenched in all the other variables and in fact becomes harder to detect. And then you actually give the data scientists and engineers and companies an out, which is like, hey, I don't even have race. How could I possibly, one, be racially biased, and two, how could I even know if I'm racially biased because you're not allowing me to have the variable? So Yanis, I think you were suggesting maybe if the sensitive variable is not available, we've been arguing very heavily that you have to have access to these sensitive variables. And in fact, what we do with the interpretable model is something shocking, which is we almost always include the sensitive variables, the ones we're most worried about bias. We include them as input variables. And we allow the model to be as biased as it possibly can be on those sensitive variables like race, gender, and socioeconomics. We allow the model to be as biased as it possibly can be. And we allow it to do that for a couple of reasons. One, you can see what bias then is in the data. Okay, because the model is very interpretable, we can actually see the bias, and that's great. It's always good to know what bias is in your data set. Secondly, we can correct the bias. That is, by allowing the bias to be sort of localized onto some of these attributes, we then have a way of being able to edit the model and eliminate most of that bias. And then even if you think that's not a sufficient correction, at least you can do things where you can do some other methods, perhaps to correct the model, make it less biased, retrain the model again using the sensitive input variables. And if you see that the bias has gone away now on those sensitive input variables, then you know whatever you did to the data to try to repair it was a successful repair. But one thing we find is really important is there are certain kinds of bias we're all sort of tuned to look for, like race bias or male-female bias, things like that. But there are lots of kinds of bias, and some of them are surprising. And what we like to do is train the model with all the available features, including these ones that we might worry about, and then let the model show us where the bias is. We don't like to go to the model in advance and only test for biases that we have anticipated, because guaranteed there are other biases we did not anticipate that are in the model and we would never have thought to test for them. Whereas if the model's interpretable, we can often see these things, and that's really, really valuable.
We are coming to the end, and I would like to throw one more question and then have each one of you answer for maybe 15 seconds, 20 seconds each. So your just a very brief thought on that. So how close are we in having these models being implemented in practice, and are these models going to be eliminating physicians' jobs, or are they there to help the focus physicians on what they do best, and also be using the models to help their work?
So how close are we? We're here. I mean, we're using these models today. In terms of, are these going to eliminate healthcare workers? No. Hopefully that was one takeaway from my talk. We need human AI collaboration for these things to really work.
I agree with Jenna, and not just because my little sister is a doctor, so I can't say that she'll be out of a job.
Rick?
Definitely the models are already being used. We do find that doctors, once they use intelligible models, they're never willing to go back to unintelligible models if they don't have to. But the deep learning versus tabular data divide is a very real divide, and you just have to use deep learning for certain kinds of things like images. I'm sure there will be some very narrow parts of medical science that will be replaced. Humans will be eventually replaced, but I think they're going to be very, very narrow. Already doctors don't like to, have to manually determine dosing. They like using automated systems to do things like dosing. There may be certain little parts of radiology where maybe an AI system will ultimately be better than the doctors, but this is going to happen very slowly. And I completely agree with Jenna and Emma that right now, what hopefully we're doing is we're building, assistants that will just sort of help doctors perform better.
All right, thank you. So I would like to thank Rick, Emma, and Jenna for joining us today. And so that brings this session to a close. I would also like to thank a number of people that have contributed to recruiting all of you to joining the session: Eric Kolachik, John Liagouris, and others at BU have provided suggestions.